Yeah.
My name is Edmund Howe. I go by Randy. I'm a psychiatrist and a lawyer at the Uniformed Services University of the Health Sciences, and I'm going to share some points in an article called Reflections on Engaging the Potentially Difficult Patient. I start off the article by pointing to another article in which there's over 100 psychiatrists who were treating outpatients and experienced problematic behaviors with their patients, and they discuss how over 50% of them believed they caused those difficult reactions. How might I have come to have some ideas as to how care providers might avoid this sort of problem? Well, as a psychiatrist, I often have patients tell me about what they experienced that was problems for them with other doctors. And so that's one source. With those sources, I've sometimes sat in conferences on ethical problems that persons have encountered, and as they share the problems with difficult patients, there is a point where almost invariably the person speaking with the patient has given, for example, a command of some sort as opposed to asking and being optimally respectful, and that's when the speaker talks about the situation switching to the patient becoming difficult, and of course that has to do with the care provider's behavior, not the patient. So the overall theme of this paper is how difficult patients may be, in fact, not difficult patients, but care providers who may have created that sort of behavior. Well, what do I cover in this article? I speak first about those who can impose their ethical views, care providers, because they have the power to do so, but not the ethical justification, but don't know that they're doing that, and then are surprised when patients object. Well, even if one is sufficiently aware of one's lack of ethical expertise, merely because they have experience and medical expertise, they may have sound recommendations to make. I discuss, secondly, in the article, how care providers can go about sharing those recommendations, which is really seeing first if patients want them. I discuss how doctors and other care providers can recognize their own biases and avoid imposing them. Now, one of those biases is, of course, their concern about the law and their fears that they might do something in violation of the law. I give several examples of how care providers might best deal with that conflict. One, for example, is one that existed in the past, namely anti-suicide contracts. It was at some institutions not too long ago required of care providers when working with suicidal patients to have them sign a contract indicating that they wouldn't try to take their lives. Well, the care provider there is in a bind if he or she suspected that this might cause a difficult patient, which in some cases it has, and so I discuss how care providers might ideally deal with that conflict between the law and what they believe is best with their patients. Then I speak some specific interventions. The first one is when with the patient, to repair. What that means is to look for any nonverbal sign that the patient may be uncomfortable. If so, to immediately interrupt the proceedings, inquire, own up to one's mistake, and then say explicitly, "I'm sorry." A second intervention I cover is to validate something that the patient is saying, because no patient ever does not have some valid view that he or she is putting forth. For example, Leston Havens, a magnificent psychiatrist who was up at Harvard, when with schizophrenic patients who would speak in what psychiatrists describe as a word salad, would speak to them and say that they were poets. That is validating what they're doing, in that that is what poetry is, to see associations. I go on beyond simply validating the content of what patients say to talk about the possibility of validating the character trait of the patient in sharing that content. For example, when a patient might be angry at the doctor or care provider might say, "I appreciate your being able to share your anger with me because then I can work better knowing how I can meet your needs and those of other patients." I then speak of the importance of care providers before coming to the bedside or to patients' relatives to look for any hidden agendas. They might have, for example, an agenda of a patient who was insisting on using more and more blood that was depleting the hospital's supplies to somehow get the patient to see that. That would be problematic. I secondly speak of how doctors should be aware that any information they know of that could be beneficial to a patient and influence their choice, they may have an obligation to share that with patients so that they can make better decisions. And I speak of, again, a conflict potentially in the law. And here it's when the law might, for instance, require a certain order of surrogate decision makers to take place, a so-called lexical ordering starting with one's spouse, for example. But what the care provider may do is share with the various family members involved how they can discuss and come up with some sort of compromise, as opposed to doing what the law suggests, namely leaving the decision up to the spouse. I then speak of the importance of going to the bedside, of the opposite of recognizing an agenda, and then how to deal with that, appreciating the fact that the patient may think the doctor has an agenda, such as if he or she is from palliative care, they may think the doctor is giving them a death sentence. Rather than that, the doctor should share why he or she isn't there to relieve that patient's anxiety. I stress also that early on in any such interview, the care provider should ask what's important to the patient at that moment. It may not be to the patient whether he or she has an illness from which he or she will die. It may be who will take care of his or her cat if he or she has to go into the hospital. I speak of the importance of doctors doing something immediately if they can, or explaining why not. For example, if there's a biopsy which could be malignant or not, the care provider would say, immediately when I get the results, I will contact you. That's very relieving to a patient, even trying to do the biopsy as rapidly as possible, that the patient can have that information. Similarly, I speak of the importance of doctors making arrangements so that patients can get information they need on a 24/7 basis, as opposed to having to wait 8 hours with some sort of fear. I suggest finally that doctors should look at where patients are at, what they're willing to do, and then ask the question, what can I do to go from where they're at, what they're willing to do, to go forward from there? Because if I take a stand and say, this is our routine, our standard of care, you must do this, that's inviting the possibility of the patient feeling rightly or wrongly that he or she can't do it. I hope you enjoy the article, and I'd love to hear from any of you that want to write me questions about it. Thank you very much.